question during the session, please type it into the chat box. The moderator will read your question to the presenter during the Q&A session. And additionally, if you would like to ask your question directly, please use the hand raise feature in Zoom, and you'll be invited to ask your question during the Q&A session. Moderator today is Dr. Henrik Ullman. Dr. Ullman is a diagnostic and interventional neuroradiologist and is an assistant professor in the Department of Radiology at the University of New Mexico School of Medicine. Dr. Ullman received his medical degree from the Karolinska Institute School of Medicine. He also has a PhD from the same institute, Department of Neuroscience, where he researched on tracking and predicting cognitive development using MRI. Dr. Ullman has received several awards and grants, and he has published, several articles in peer-reviewed journals and has made many presentations at national and international conferences. Thank you, Dr. Ullman, for joining us today. Our presenter today is Dr. Mesha Martinez. Dr. Martinez is a pediatric radiologist, a neuroradiologist, and a neurointerventionalist. She received her undergraduate degrees in psychology and biological sciences from the University of Delaware in 2005. She gained her Doctor of Medicine from Temple University Hospital in Philadelphia in 2009, with subsequent training in internal medicine, and she completed a diagnostic radiology residency program in 2014.
No worry. Yes. Okay. Thank you so much for that introduction. You guys know me pretty well, I think. I am going to be talking about vein of Galen malformation today. And so good evening, good afternoon, good morning, wherever you are. I'm super excited to talk about this subject because it's dear to my heart. I feel like that all the many years of training that the professor was going to say that I did was basically for this type of patient. When I chose to do pediatric radiology, neuroradiology, neurointerventional radiology, I knew I wanted to specialize in pediatrics. And so for me, the patient who is going to present with the vein of Galen malformation was the training for the marathon that I knew would eventually come. And so today, we are going to talk about the vein of Galen malformation, and I have three simple ideas that I want the audience to take away. Yes, we will be oversimplifying today because this is how you start building a foundation, and this is how you can really learn something that's very, very complex. I don't want to underestimate or I don't want to make it seem like it's super, super easy. But again, just learning the basics helps us to learn the complexity. So we will define what a vein of Galen malformation is. It has very strict definition when you're going to call it on imaging. And today we're going to actually outline what are the necessary vessels of involvement in order for you to say this child, this patient, this adult even has a vein of Galen malformation. And then number two is going to be the various clinical presentations. So vein of Galen malformation is commonly thought of in the neonatal population, being diagnosed in utero or being diagnosed later after birth. But patients can be diagnosed later, during infancy, during childhood, even into adulthood. So we'll discuss the different clinical presentations. And then last, we'll land on, very briefly, believe it or not, on treatment. Because the ideas are basic. You are dealing with an AV shunt. So just like you're dealing with an AVM or AV fistula, the ideas are the same, but also because the treatment would take a session alone, but understanding the anatomy and the disease process and how it's impacting the patient should always be focused on first. All right, so starting off with, when do we call it a vein of Galen malformation? What is the true definition? Well, number one, you do have to have an abnormal artery to venous connection. If there's no shunting, it's likely not a vein of Galen malformation. It's not. But the importance of understanding the vein of Galen malformation from all the other AV shunts, whether AVMs or AV fistulas, that's the only two types of AV shunts you can have. You have to understand a little bit about the embryology of the vessels when they're forming in the brain. And so, number one, we can see in this classic picture of a neonate who is intubated, presenting with a vein of Galen malformation, that we don't have the vein of Galen. This is not the vein of Galen. This is called the median prosencephalic vein of Markowski, if you really want to get fancy with it. But the median prosencephalic vein is an embryological structure that usually recanalizes, reforms into two structures that we're very familiar with. One are the internal cerebral veins, and two is the vein of Galen itself. When the internal cerebral veins do not canalize and form, and the vein of Galen doesn't form, you end up with this median prosencephalic vein, which is an aneurysmal dilatation of the vein in a sac. And so if it's not involving the median prosencephalic vein of Markowski, it is not a vein of Galen malformation. And sometimes what happens is you'll have normal embryologic formation of the deep venous sinuses, and you'll sometimes have an AVM that is draining into the vein of Galen proper, but this is not a vein of Galen malformation. Okay, so here we can see this schematic that's basically showing if you don't have these internal cerebral veins that are draining into the vein of Galen, but you have this aneurysmal dilated sac called a median prosencephalic vein, then it's not a vein of Galen malformation. Some other structures that can form in association with this abnormal time in embryology is the falcine sinus, which will connect directly to the superior sagittal sinus. And sometimes you'll have the straight sinus, but sometimes it may not appear that this formed either. So remember, it is an embryologic variation that somehow got confused during development. And then part number two, we said you have to have an arteriovenous shunt. There's very defined arteries that are going to connect with this vein during development because of when this error in embryology happens, there's going to be certain arteries that are going to be around it that actually join in or shunt to this median prosencephalic vein. And, even as I was preparing this talk, and I've done a few talks on vein of Galen malformation now, you learn more and more because there's really not a lot in the literature about why does this happen. We are guesstimating when does this happen. We know that sometimes there's a genetic association with patients with capillary malformation AVM syndrome or RASA1 mutations, but we really don't understand what causes this not to develop, what causes the arteries to start plugging in. So what arteries are going to be involved? It has to involve the choroidal arteries. We're familiar with the term because we're talking about the choroid plexus and the arterial system that's responsible for giving flow to the choroid plexus. So you have your anterior choroidal arteries and you have your posterior choroidal arteries arising from the ICA as well as the PCA. And then some other arteries that can join in the fun, for the lack of a better word, are going to be your thalamoperforating, your pericallosal arteries from the ACA, and then your quadrigeminal arteries, which are the arteries that are going to actually supply the quadrigeminal plate. So, very strict definition. If you don't have this combination of things, it is not a vein of Galen malformation. It is some other type of AV shunt, whether it's an AVM or an AV fistula. Okay. Hopefully there's no questions about that, and there will be a little bit of interaction with my audience because you guys know that I hate to be the only one talking, and especially when it comes to education, the more I'm asking questions and hearing back responses for you, the more I know that I'm teaching something and making sense. So now that we've established what is a vein of Galen malformation, what arteries involve, what veins are involved in order to make this AV shunt, there are two flavors of vein of Galen malformations. There's going to be the mural type, which I explain is very simply direct AV fistulas, meaning I have an artery that directly connects into the wall of that median prosencephalic vein. Okay, mural type. Choroidal type is more to me in my mind, even though it is an AV fistula because you have direct connection between artery and vein, it has more of a nidal type of network. It's not called a nidus, but these arteries that connect into the vein, they have this network, or it's almost like a pure arterial malformation where the arteries are very squiggly and they have multiple channels and it's multiple arteries coming off of arteries. And so I always like to imagine this more of a AVM type of vein of Galen malformation just for teaching purposes, even though it's not. These are truly AV fistulas where there's an arterial to venous connection without a nidus, but the choroidal type has more of a nidal appearance. Now, what is the importance of having the two types? Is it just us being nerds or us just liking to classify things? No. Again, it goes back to this likely has a lot to do with development and how these things form, which we don't know a lot about still, unfortunately. No worries, audience. I plan on working on it. But mural types are more likely going to present later in childhood because there's usually either one single arterial pedicle leading to the vena gala malformation or just a few more. So it's almost like you can have a single hole AV fistula, which we do, and we can have multiple hole AV fistulas, which we do. And so your mural vena Galen malformation comes like that too. You can have one single artery causing this abnormal shunting, or you can have multiple arteries. And so with mural types, the patient is more likely to not present earlier because the arterial inflow to the vein is a little bit less. Now, choroidal types of malformations are very, very complex. They are very hard to treat, and they cause a lot more damage if you have one. And so patients with choroidal malformations are more likely to present earlier because you just have so many arteries, this network of arteries that are directly dumping into the median prosencephalic vein. And so there's a lot of arterial pressure, arterializing the venous system, and the patient is more likely to be symptomatic sooner. And so when it comes to, if you said to yourself, what is my first Van Galen malformation type that I want to treat? You probably want to do the mural type, and you want to be a little bit wary or have a friend or phone a friend for the choroidal type. All right, so we're going to do a little bit of case presentations. All of these cases are true. Patients presenting at the ages with these symptoms. And we're going to just talk about from actually oldest, which we commonly don't think about patients presenting at the age of 17 with a vein of Galen malformation. And then we'll go to the more classic pattern of presentation, what most people think about with our younger neonate and how they present with vein of Galen malformation. But this was a 17-year-old male who was presenting with just the worst headache of his life, sudden in onset, and he was vomiting. Unfortunately, this was a video, but for some reason my My videos are not working on my Mac. And so I'll just kind of walk you through it. So here we have great gray-white differentiation. We have increased attenuation within the ventricles. Everything is inside the ventricles here, third ventricle, lateral ventricles. We can see a little bit extending into the body here. Um, Young patient, you can tell because he doesn't have a lot of gyri sulci prominence, but he's presenting classically like a patient who has an aneurysm rupture. But um, this was his diagnostic cerebral angiogram upon presentation. And so here, again, we have choroidal vessels involved. We don't have a classic internal cerebral veins. We have this pouch appearing thing. We have this choroidal appearance. And this is a classic for a Vein of Galen malformation. So I'm going to try to move my picture. I hope it's not hiding um, my screen. I hope I can, let me just, yeah, I don't want it to overlap the picture. So when you have an older child or even an adult presenting with a Vein of Galen malformation, remember, these patients can actually present with intracranial hemorrhage or headache. Um, I've seen scenarios where patients presented like this 17-year-old, where usually it's going to be the vein wears out over time. You can tell that this is a little bit smaller because you don't really have really large hypertrophy of the arteries that are feeding the shunt. But what happens with time is that the vein starts to wear out. You start getting strictures, you start developing a venopathy, and then that's usually what's going to rupture for these patients. And again, because it's involving the choroidal system, it bleeds into the ventricles because that's the space that this abnormality of development is in. And so, with older patients, you are going to have the increased likelihood of having feeding artery aneurysms. And just like every presentation of an AV shunt, whether it's an AVM or AV fistula, if the patient is presenting with acute hemorrhage, after that patient is stabilized, you are going to perform an angiography. You're going to get rid of any risk features, and then you're going to plan the treatment strategy. And risk features for the vein of Galen malformation, it's not going to be nidal aneurysms because there's no nidus, but it is going to be, are there any feeding artery aneurysms on the parent artery pedicles? Here, again, it was likely he bled from the veins. And what you see when it's venous bleeding on the brain versus arterial bleeding on the brain, the recovery is a lot better. There's a lot less vasospasm associated, like you do when you have an aneurysm rupture. And that's why a lot of these patients and younger children do a lot better because it's actually a venous rupture. When it comes to the type of Vein of Galen malformation, when you're dealing with older children and adults, it's going to be the choroidal or mural type equally. It's a 50-50 chance. And then the last thing that I was saying, when I see patients present older, I have actually seen patients where they're thrombosing off this abnormal arterial to venous shunt connection because usually the venous system wears out, that you start getting stasis in the vein, and then that leads to the whole thing thrombosing off. Now, the question may arise if a patient is presenting with symptoms and the vein of Galen is thrombosing off, what do you do? Nothing. You don't necessarily try to go treat it. You try to see if it's going to finish the job. But if it's caused symptoms or stroke, you do have to anticoagulate. And then this may reopen it and then you have to treat it. So that's a very interesting scenario. Any questions about that? We can talk about it more. All right, now it's time for the audience to join me. We went over anatomy. We went over vessel involvement. We went over types of Vein of Galen malformations. So I'm going to let the audience volunteer and tell me a little bit about these pictures. So this is a 6-month-old male. He was born term. He went home with mom. Things were going great, but then mom started noticing as he wants to try to start scooting around. He seems a little bit unsteady, trying to get his balance to start crawling and moving, and his head keeps getting bigger and bigger. That doesn't run in their family, and it seems to be a sudden jump on the scale. All right, so audience, I'm going to let you look at these pictures. We have our sagittal T2. We have a, what did I put? Another fluid weighted sequence. And here we're actually showing you a gradient echo sequence to kind of show you the venous involvement. Okay. Some things that we can notice are there's dilatation of the ventricular system, and we know that the ventricular system is heavily dependent on venous drainage. CSF has to drain through the veins, and when you start messing with those dynamics, it can lead to ventricular dilatation, hydrocephalus appearance, although there's not an obstruction. It's more communicating, and um, yeah, patients can develop issues with coordination and vomiting and evidence of intracranial hypertension, et cetera, et cetera. All right. Now, this is where I need you to tell me, one, is this truly a Vein of Galen malformation? And two, of the two flavors of Vein of Galen malformations, if it is one, what type of Vein of Galen malformation is this? Anyone want to volunteer for my audience? Don't be shy now. It's only 28 of us, small group.
Feel free to type your answers into the chat.
Okay, I forgot. It's morning for me, and everyone else is like, oh, we're trying to get through this so we can go to bed. Um, Dr. Uche, look, I'm pimping him.
Say again.
Would you like to say the answer? What type of, is this a Vein of Galen malformation? And what type is it based off of this angiography?
So from your initial description, we don't see an internal cerebral vein. And you just see the dilatation of what looks like a median cephalic vein. You can see just possibly just one or two inputs into it. So this would be
Yes.
classified as probably a neurotype, I'd say.
Yes. And did I mention the answer was on the screen? So no, you
Ah,
killed it. You killed it. You killed it. So this is going to be the more common type that you get, not necessarily that's diagnosed in utero or right after birth, but kid goes home, things are good, and then this slowly becomes an issue over time as the baby grows, as the arterial venous connection continues, and so Dr. Uche, he hit the nail on the head. This is definitely a Vein of Galen malformation. You can see this aneurysmal dilatation. You don't really see the normal straight sinus to deep venous sinuses anatomy. You even have a falcine sinus going on here. This looks like it wants to be an occipital sinus. Things kind of change, and that's what makes pediatric neurointerventional radiology so fun because you really have to understand embryology, you really have to understand anatomy, and then with little people, if something is wrong, it's really wrong. Okay, and so again, we have this nice large arterial feeder coming here and plugging into this aneurysmal dilatation. You can see that it looks like the pericallosal arteries are trying to join the party. This is classic for moral type. You can kind of see there's a feeder here too. There's not just a single pedicle, there are multiple pedicles, but you don't have that nidal appearance like we had on the 17-year-old who suddenly experienced intraventricular hemorrhage. So, infants presenting with microcephaly, a hydrocephalus, not obstructive, developmental delays. They might develop a little bit of mild heart failure. And a lot of times for children, whenever they're having issues with venous hypertension or they're just stroking, children present with seizures. They don't present like adults do. You do get a little bit of the cerebral still phenomenon at this age and with this type of Vein of Galen malformation. So you can start getting a little bit of um, delayed cognitive development, lack of progression in milestones because you're not, the blood is shunting directly to the shunt and not necessarily perfusing the brain. Okay, so you start getting decreased perfusion to the cerebral hemispheres, and this is something that you definitely want to take care of and treat so it doesn't impact the rest of their development. And so here we have our last case before we go into treatment. And this is the most common scenario that we're familiar with. This was a case, my first case as a new attending when I started my first pediatric neuro IR program. And this baby, I'm going to tell the story because it forever changed my life. So it was during 2020. I had been practicing since 2018, and they told me, Dr. Martinez, there's a baby on the way. They were not diagnosed in utero. Um, Mom is unstable because the birth was a little bit risque. They ended up having to do an emergency section. It wasn't progressing. Mom suffered an injury. So mom is at the outside hospital, but baby is coming to our hospital uh, by helicopter because baby is not doing well. And so, again, mom had a healthy pregnancy, no issues, did end up delivering at the time she was supposed to. This baby was not premature, but had some difficulty for baby to progress and be birthed. There was lack of progression. Had to have the emergency C-section, and then baby came out. APGAR scores were very low. Baby wasn't really breathing, and then baby started seizing. So here I've skipped the brain MRI because I want us to realize what type of vascular vein of Galen malformation this is. And then I want us to think about, why is this baby doing so poorly? Okay, does anyone want to volunteer? I'll give it a little bit of time, but no pressure. We're all friends here. Okay. So, one, why this baby is doing so poorly is that these vessels are gigantic. Remember the 17-year-old that I said? He probably got to the age of 17. His vessels were not hypertrophied. You could see that it was more the venous venopathy that caused him to become symptomatic, and probably the vein wore out, ruptured in his interventricular system, and that's how he became symptomatic and presented. Whereas this baby, we see that this internal carotid arteries are pipes. They are huge. It's like these are taking up the entire baby's neck. Okay. Same thing for the vertebral system. You have your V4 segment here, both sides joining this basilar. I mean, it looks like a tree trunk. And mind you, this is a little, I think she was 10 hours when she got to us, 10-hour baby. And we have more vessel almost than her head. We do have a moral type of vein of Galen malformation where we're not getting that nidal type of look and network. But if you also want to pay attention to some interesting things here, what is going on with her arterial system outside of intracranially? We have the vein of Galen malformation, but we have this extensive network that is involving her spinal system. Um, some images I'm not we it looks like we have some more like pure arterial malformation, sort of nidal. This was not shunting, but it was just excess vessels. Then you had your shunt here, where you're actually seeing the median prosencephalic vein, that pouch again, and here you have, it doesn't look necessarily like the normal system or sinus. Um, so vein of Galen, mural type, but huge feeders. And this is overwhelming baby to the point where they're in heart failure, they're in distress, they're seizing, they're not perfusing their body well because everything is focused on going through this useless shunt inside the brain. Now, someone has to volunteer and answer this question. So if this was your first case, like it was my first case, and you're always going to start off by stabilizing baby, getting baby on the scanner, you do not want to go to the angio suite blind. You really need to know what's going on. And in this scenario, by getting this imaging, you actually want to understand if there's anything you should do. So I put up a normal picture to compare for the same age baby, 10 hours old, to what our baby looked like. Does anyone if this baby's in failure and they present it to your hospital, would anyone vote to treat this baby? And you can just say yes.
No.
No, yeah, no, no, no. And let me show you some more pictures. So when it comes to the neonate, their brains are very watery. So you kind of have to read your MRIs a little backwards, okay? And the main thing is with DWI, when we are looking for cytotoxic edema or brain that's infarcted, we usually like to look at the DWI instead of the ADC. But for neonates, it's more important to look at the ADC. And anytime you're seeing black like this is destroyed brain. Okay. So if you correspond this hyperintensity to this darkness here on ADC, it's basically saying this is brain that's dead. So not only do you have what we call brain melt, that is when you start losing parenchymal volume. The brain is just dying and liquefying and going away. And that's secondary to increased venous hypertension and the inability of the brain to drain through the normal veins because this venous structure is abnormal like it's supposed to. It's the hydrodynamics of the brain that are so dysfunctional that the brain just starts to melt away. And so here, this is why if this baby would have lived, you start seeing just calcifications form from the venous hypertension and the parenchyma being dead, because this is very severe venous hypertension that causes brain melt. And so brain melt is one of the indications that this baby would not have any type of life. It would be severe cerebral palsy. And it basically would be the brainstem just keeping baby alive. And we are taught that when it's an emergent situation and you have to make a decision, could I have treated this baby? Yes. But do I want to? No. And so I had to counsel this new mom and dad that there was nothing that we could do for their child based off the fact that the injury to the brain was so diffuse and so severe. This part of the brain is dying too, um, that there was nothing to do. And so oftentimes we talk about the Spicetre score when a baby is in heart failure, presenting emergently to the hospital, whether the diagnosis was known or whether the diagnosis was unknown, where we're looking at how is baby's cardiac status, how is baby's respiratory status, how is cerebral, how is renal, how is hepatic. And so this can be a very um, big effort. And what I teach is that hospitals who have all these specialists for the neonates need to be involved. And just like you have a stroke protocol, you should have a vein of Galen malformation baby and failure protocol. So you can activate the system, get everyone to weigh in and assess to see what's going on with baby and whether baby should undergo treatment. However, given the fact that this is falling out of favor, the main thing that we are saying now to assess if a baby should go for treatment or not, and whether or not you have all the resources like cardiacs in the hospital, they may have went home for the day, et cetera, et cetera. The main thing you want to see is that if there's reversal of diastolic flow within the aortic arch, okay, then that is an indicator that this baby is not going to perfuse the rest of the body because all of the flow in the aorta is actually going towards the head. And so that's why you're going to have issues with the lungs, the kidneys, the liver, because all the blood flow is going to the head instead of going to the body. And so now we're saying, hey, you don't have all those people on board. You need to make this quick decision. Just get the echocardiogram, get baby stabilized. A lot of them have issues with breathing and pulmonary hypertension, etc. Do the echo. If there's reversal of diastolic flow in the aortic arch, meaning everything is preferentially going through the cervical vessels to the brain, then this baby needs to be taken for treatment as soon as possible. The next thing you do is your MRI, MRA, MRV. You check to see how brain has responded to all of this. If brain is gone and brain is dead, then you say, we're sorry, we're not going to rush this baby off. But if there's still brain there, no brain melt, no huge infarction of all the brain parenchyma, then you go ahead and take the baby to the angio suite. And so Neonatal vein of Galen malformation. They can present with cardiac issues at birth, where this baby did. Her APGAR scores were very low, or shortly after birth. Only 40% will be diagnosed in utero, okay? And we have a whole protocol where if a baby has a vein of Galen malformation caught on their anatomic exam, where we will counsel mom and dad, tell them what the expectations are. We will perform serial MRIs as it gets close to birth, because sometimes if baby is deteriorating, and that was a new paper that we published probably 2 weeks ago in AJNR or 3 weeks ago in AJNR. If baby is deteriorating inside mom, then sometimes it's best to go ahead and do early delivery. And there's actually 2 trials in the United States, one at my old institution, one at Boston Children's, where they are doing in utero treatment for babies who have poor prognosis to make it to delivery. And so 40% will be prenatal diagnosed. We're hoping to catch those babies, and now they're doing actual percutaneous treatment in utero. But if not, baby's born, remember 60% are going to present shortly after birth or at birth with extreme respiratory distress, possibly seizures. And most of the time, the type of malformation that you're going to see at this age group, and the reason why it's causing heart failure and is so severe, is going to be because it's choroidal type. And again, that goes back to these arterial networks that are connecting to the vein instead of the simple straight artery to vein fistula like in the mural type. I show this chest x-ray because again, we are simplifying ideas here, but it's nice to know a lot about neonatal care when you're dealing with treating these babies. And here we can actually see there's an umbilical, arterial, and venous line. And the reason why I say that is because when these babies are being born and presenting in distress, it's going to be very, very important to have an umbilical arterial catheter. You want to be able to know how to identify it. You want to be able to know that it's in the right place, because this is going to be your access. Some of these babies are going to be born premature. Common femoral artery puncture may not be accessible or feasible because they're so tiny and they're so just being born. Like the youngest that we had, I think was a 36 weeker. I forget how many kilos, but he was 10 hours and very tiny. But thank God that we had our neonatal ICU place an umbilical arterial catheter right away. And then we were able to exchange this for sheath and keep that sheath in for stage arterial embolizations, but know what that vessel, your access, is doing, just like you know what your access is doing for any other procedure that you do. All right, last part, treatment. Number one, NVCA glue is preferred, okay? We don't really like using onyx for vein of Galen malformations. It is going to pass through the system. You're dealing with a really fast, high flow shunt. And so you really do not want glue or onyx traveling to places that you don't know it's traveling to, and especially to the lungs, because these babies have severe pulmonary hypertension already, and they're struggling to breathe as it is because they are also dealing with cardiac failure. So NVCA glue, we talk about using a pure glue type of mixture where it's just a few drops of Lipiodol. You're mixing it with a tantalum so you can be able to see the glue, and then the rest is glue. And basically, this allows you to create instant plugs as soon as you inject and it comes out your catheter. This is one of the things that I teach with the MBCA glue company in order to teach people how to prepare for this case if they ever experience treating vein of Galen malformation. The goal is going to be disconnect the artery from the vein. And the goal is not with these little babies to cure the vein of Galen malformation. It's to slow down all the flow going towards the head so it can start going towards the body. And sometimes it only takes one shunt or two pedicles, and then you stop. The last thing you want to do is take out all the pedicles, have a beautiful angiographic result, and then realize now the whole venous system is shutting down because it was used to all the flow. You've taken away this arterialized flow and the veins go lazy. And that's for any AV shunt, whether it's in the spine, whether it's in the head. You need perfusion, you need flow, I should say. You need flow through the veins. And when you take away the rapid flow that they're used to, they just start clotting off. So you don't want to do this all in one setting, but you want to do it enough until your vital signs stabilize. And you'll actually see that your anesthesiologist will say, hey, we're ventilating better. Heart rate's coming down, blood pressure is normalizing. As soon as you take out the pedicle, you'll start seeing improvement in the vital signs. So as soon as your anesthesiologist says, oh, baby's stable, you say, oh, we're done for today. And then you plan to bring baby back as frequently as needed. You always get an MRI, MRA, and an MRV first. It's nice to have a vascular malformation intracranial neonatal protocol, but mainly it's because you want to make sure brain parenchyma has not been devastated. I cannot express how important it is to have an umbilical arterial line. Sometimes the NICU can't get it, or your ICU intensivists can't get it. And so you're going to have to think about common febrile artery access. You have your ultrasound. We have small catheters to get the job done, and you may be just using a microcatheter to treat, but that's better than nothing if you are trying to save a life. Now, how does treatment go? 60 to 70% of children now that we're not doing good old surgery anymore and we're doing endovascular treatment will have good neurological outcome, especially now that our devices have improved. But there's still a pretty high number of mortality, 10 to 20%. And those are the severe cases like I showed you for our neonatal case, where it's not diagnosed in utero, it's not seen, it's missed, could be one or the other. And then baby is just presenting very, very severely. And I believe that that baby that presented for my first case of Vein of Galen actually had probably like a RASA1 mutation. They didn't do autopsy or anything like that, but all of her vessels, even in her neck, were abnormally formed. There was tiny little arterial networks everywhere. So she had a significant vascular developmental issue that made her case so, so severe. And the complication rate for embolization is still as high as 35%. So like I said, this is not a treatment or your first case out of fellowship. This is preparing through, like you prepare for a marathon for when this baby arrives. And so thank you so much for listening. Again, it's such a fascinating disease. I could do part 2, could do part 3, because there's so many parts of this that are important for understanding and for treatment. But I think this is a good start and a good foundation. And I hope that no one fell asleep.
Thank you very
Questions?
much, Dr. Martinez, for a wonderful presentation. That was a very good overview of a very complicated topic. And thank you very much for sharing your expertise on the topic. The floor is open for questions. You can either raise your hand or put a question in the chat. We have one question in the chat so far by Dr. Kinsley, and who's asking if open microsurgical treatment is possible.
No, we do not recommend that being done anymore because it's just basically going to be a bloodbath, especially if baby is in heart failure, baby is in distress. Even if you have a stabilized patient, now endovascular treatment is the standard of care because the mortality and the neurological outcomes were way worse back when they were doing it. Now, the question may arise, well, no one's doing it now. We have way better equipment and microscopes. Uh, it's just oftentimes that AV fistulas are not treated with open neurological surgery. So, no, I would say it's possible, but it's not the standard of care.
that's a very good answer. Yeah, personally, I've never seen anyone attempt open microsurgical treatment while I've been in this field.
Right, right. Agreed. And usually even like AV fistulas, they're like, let's call neuro IR. We're not taking this baby or person to surgery. AVMs, yes, but AV fistulas, no. And that's what Vein of Galen really is. It's direct arterial to venous um, connections. How frequently have you had a case? That's a great question too. I probably say I see a case every 3 years, believe it or not. And the place that I trained and where I was, um, when I came to my last, at my place that I first built my program, when I came to my last institution, I would say we do probably see 2 to 3 patients a year. Um, and now that I'm independent, we'll see, because I'm hoping that people will ask me to come visit them and I'll go treat baby on demand. That's my new goal. So, but yeah, it's very uncommon unless you're at the bigger centers. Boston Children's, you're going to see a lot more commonly. Where I trained at John Hopkins, I would probably say we had about 3 to 4 babies a year. And I was there for 2 years. So I got a lot of my cases from that time and my knowledge on how to treat them at that time. We were covering also 2 hospitals. We were covering John Hopkins Hospital, Children's Hospital, as well as DC Children. So we would get all the catchment in that area. But yeah, your bigger centers are going to see more per year, more than one baby a year. But your smaller centers may not see a baby but every 3 years. Any other questions? Okay, I have one. Why? Oh, you have one. Okay, go ahead.
Thank you, Misha, for a wonderful presentation. I think I remember the first time I came across you was when you gave a talk. I don't know if you remember.
Mhm.
I think with one of your former bosses, Professor, I'm trying to remember his name.
Bernstein.
Yes, Bernstein. Yes.
Yes,
So you're
yes,
both
yes,
talking
yes.
about this topic, and I think that's how I got in
Yeah.
touch with you. It was also a
Yeah,
very
yeah.
wonderful presentation. So thank you.
Thank you.
So
Yeah,
good.
no, I did
Yeah.
go to Mount Sinai and I was with Bernstein. And again, that's another huge referral center for the Vein of Galen malformations. And that's probably some of my cases that I got too, because we saw all age groups, patients who were older, undergoing stage treatment, and then of course the babies that were presenting. So yeah, yeah. It was nice to be on the stage with him because he is the expert. Now that he's retired, I will take over for now.
Absolutely.
But no, I have a question for the audience. And if you
A
ever
quick
want
one.
to,
I
oh, go.
apologize. I was going to ask you, you touched
Oh, no.
upon in utero. So you will do antenatal ultrasounds and we find them.
Yes.
Is there any provision for, treatment in utero, or do you know anything about what's going on that
Yes.
front?
So I actually should have put it in my presentation. I didn't think I was going to have time to talk about it, but I saw you guys extended this to 9:15. Do you want me to pull up my slides so I can talk about that a little bit? Because it doesn't seem to be questions.
Okay, I think
Okay.
if you can run through it quickly.
Or I can just talk about it. So there's 2 centers right now who are doing in utero treatment of Vein of Galen malformation. The paper that we recently published shows that if the median vein, the median prosencephalic vein measures over a certain size, and I can't remember off the top of my head, I want to say it's a centimeter, but I don't want to misspeak, then those patients will not likely make it through their full term before their brain melts. And so the treatment that Texas Children's Hospital is doing right now consists of delivering uterus, uh, puncturing through uterine wall, and treating the baby with MBCA glue to slow down the pedicles, redelivering the uterus inside belly, and then letting mom go to term. I know there's a trial, and I know they would love if there's any cases in Nigeria, anywhere, all over the world, where mom is presenting, baby is not looking great on anatomic scans, send that baby in because their goal is to um, catch babies who are not doing so well in utero, to do this procedure and try to save their life. The first trial that's currently ongoing at Boston Children's Hospital by Darren Orbach, and the first case was actually done in France by my good friend Gregor, they're actually not delivering uterus out of mom, but they're actually puncturing through the skin, and they are placing coils directly under ultrasound into the median prosencephalic vein to decrease that arterial venous shunting connection. And of course, because a lot of the pathophysiology behind this, why babies do so poorly, is the severe venous hypertension and the fact that the venous system is overwhelmed and not nurturing the brain or doing the job of the brain that it needs to. So they're just placing coils into the median prosencephalic vein, and then there have been successful cases. One thing that they have been noticing is that baby ends up delivering sooner and not being able to go to term. They've had a few deaths associated with this, but it's a working process. And so you have two types of procedures, two trials ongoing now, both offering where we're trying to disconnect or slow down blood flow through this abnormal connection so baby can be born, and then more treatment can be done at a later time when baby's allowed to grow. So it's actually very fascinating.
Interesting.
Yeah.
We have a very, very good question in the chat by Dr. Opara, why we shouldn't, why it's said that we shouldn't shunt patients with hydrocephalus and vein of Galen.
Yeah. So, there's the idea that maybe the sac is actually causing compression on the tectum and the cerebral aqueduct is narrowed, and you're getting this sense of obstructive hydrocephalus causing the third and lateral ventricles to balloon. But oftentimes um, it's not due to that. It's due to hydrodynamic dysfunction, where you definitely have these veins that are supposed to drain the vein. You have these veins that are supposed to drain the brain. I always do that. They're supposed to drain the brain, and they're supposed to drain CSF. And now that the veins are being overwhelmed by all the arterial inflow, nothing is draining. So you get a congested, waterlogged brain, and you get CSF building up in the lateral third ventricles and doesn't have the egress out the venous system like it's supposed to. And so what they have noticed is that those who undergo shunting actually do worse. Um, it is not recommended unless you know 100% for sure that this is a secondary to a mechanical mass effect phenomenon. The treatment for the hydrocephalus that you see with vein of Galen malformation is embolization. And that's just based on the data from the papers that patients do more poor being shunted. And it's likely because it's a different mechanism. It's not an obstruction from the mass effect. It's actually just severe venous hypertension and hydrodynamic dysfunction.
Thank you.
Any harm to the mom? Oh, go ahead. There was another one.
So there's a question by Dr. Kingsley, any harm to the mom?
Not that we've observed. The mom has been fine in both types of procedure, whether it's percutaneously, ultrasound guided, or whether it's the mother is having the uterus delivered. There are a lot of procedures that Texas Children's Hospital does for other conditions, such as the heart, that this is very common. There's the exit procedure that when babies are born with inability to get air in and out of their trachea, they'll partially deliver the uterus, clear the airway while baby is still attached to placenta to mom, and then deliver baby. But no, mom doesn't seem to have, of course, there's risks, but mom seems to do just fine.
Thank you very much. I have a question that I've been asked, something I've been asked to do a couple of times with, it's not for vein of Galen, but patients with bad intracranial fistulas with increased intracranial pressures that are difficult to treat and to temporize those with placing a venous stent. Is that something that you've ever had discussed about with the patient of vein of Galen?
We have. So, the largest group is Adam Reaney out in England, London, who has actually done a few cases where it's a Vein of Galen baby. You have the obstruction to the sigmoid or transverse sinuses, and that's why it's causing so many seizures, so much venous hypertension, and brain is waterlogged. And they have said that their experience of placing stents to reopen the venous outflow obstruction has caused those stents to shut down. And well, they placed the stents and then those stents shut down again. The discussion that we were having, being that I do a lot of dural venous stenting in little people, and I've never had a stent shut down, was one, what type of stent are we using? Covered stent, um, you know, nitinol, laser cut stent. Two, my major thing is what size are we using? So the venous sinuses grow to the maximum size at the age of 1. And so if we are sizing the sinus to place the stent, it probably does lead to occlusion because that's what I see on the adult side. If I oversize my stent, then it leads to increased intimal hyperplasia, and I get stenosis prior to and post to the stent. And that was a paper actually performed by my mentor, who only uses one size for everyone. And so we kind of left the discussion at that amongst us pediatric neurointerventionalists. Were we doing it the right way? And that's why we saw bad outcomes. Should we still consider doing it? I'm in the camp of yes. If there is severe venopathy, you can recanalize it and you can reopen it. Give it a try, because I mean, if they're not able to create collaterals to shunt through other places, then this is probably going to eventually be the cause of their death. So for me, it is compassionate management. It's giving them a chance, but the most important thing is don't oversize the stent. Do not measure that vein. Place the stent the size of what you measured. But
Okay,
good
thank you.
question. You're welcome. And there's one more. It says, is it safer to wait till delivery to treat? Yes, it's always safer to wait for delivery to treat because you're not dealing with prematurity also causing the picture. But if brain is going to melt because the shunt is there and actually destroying the brain, you want to deliver baby or else you won't have anything to treat when baby's born. They also go into high drops where they start collecting fluid in their lungs and fluid in their they get anasarca fluid in their skin. Um, they get ascites in their abdomen. And usually, again, when we start seeing polyhydramnios, increased fluid in mom's belly, um, we often say it's too late anyway. So it just depends on how is baby doing inside mom. If we can wait, we want to wait. If we can't, we want to deliver to give that baby a chance. If we can do it intrauterine, even better, so we can allow baby to continue to bake after the procedure. Great
Okay,
questions, everyone.
any other questions? Okay, if that's it, I want to thank Dr. Martinez very much for sharing her expertise, and I want to hand the floor back to our host. See if
All right.
of-
Thank you very much, Henrik. Thank you, Misha, for wonderful presentation as usual. Very clear and very detailed.
Thank you.
Telling you, your passion shines through your presentations. Very nice. So great. And the questions also show that people were engaged and involved. Um, we would like to inform, before we conclude today's session, I'd like to inform participants that our next grand rounds will take place on Wednesday, December the 10th. So please keep an eye out for the flyer, which we'll post later on. We look forward to seeing you there. We will share the flyer by email and usual social media channels. Feel free to invite your colleagues. And if you have any ideas for topics you would like us to be presenting in the future grand rounds, please reach out to Dr. Okafo or myself. Today's recording, as well as previous recordings of previous ground rounds will be uploaded on the WASI YouTube channel, which is youtube.com/WASI official. So you can see the link of the channel in the chats, and you can watch and rewatch and keep learning. So thank you everyone for joining us, and we hope this session has been valuable to everyone. Have a wonderful rest of the day.